So we are live. So with your due permission, shall we start the session?
Yes, let's start the session. Then,
Okay.
yeah.
A very good afternoon to everyone present on today's session. I am Nishita from IGCP Group. Welcome everyone on today's topic, how physicians should approach short stretchers. And to present this topic, we have with us none other than Dr. IPS Kochar, sir. Sir is the senior consultant, pediatric adolescent endocrinologist and diabetologist. Sir has done MD in pediatrics from the Maulana Azad Medical College, MA MS from Vienna, MRC PH from London, fellow in pediatrics and endocrinology from London. Let me share an overview of today's session. Approaching a patient with short stature requires a comprehensive and patient-centered strategy by healthcare providers. Physicians should consider the medical and non-medical factors, family history, growth patterns, and potential underlying conditions. And to briefly discuss about this, I would like to hand over the session to Dr. Kochar, sir. Sir, over to you. Please proceed.
Okay, thank you very much for this nice introduction. So today we're going to talk about, approach how the physicians see a child who was a short stature, whether he's really short stature or is he okay or fine, or does he need any investigations, and if need, what should we do? Okay, so let's talk about that one by one. So coming on to this, okay, sorry, what happened? I think I'll have to start again.
So you can stop sharing and again share.
Okay. Okay, so as I was saying that, how to approach, we'll be talking about it. It's visible now?
Yes, sir, it is visible, but your first slide is showing where your details are there.
Okay, so we'll start off, the very important thing is you see this is a cartoon which is showing that, the child tells the father that I would like to be tall, can you help? So the problem is my child is short. Okay, so this is just a cartoon trying to explain, that this is a. So what is short stage or what is growth failure? There are two different terminologies. Growth failure means when the child is weight is also affected, height is affected. Short stage is basically in terms of longitudinal when your height is not increasing to what should increase the proportionate, that is called a short stage. So growth is a very important parameter that provides insight into a child's overall health. So that's very, very important parameter. Now, what we are going to talk about is basically that, how does it make a difference? So what is short stature basically? So short stature is diagnosed when the child's height is more than 2 standard deviations below the mean or which is near the third percentile. So does it make creep to you or what? We'll just talk more about it in the next slides. So we in the general population, 3 to 5% of children are considered to be short. So many of these short children, they grow at normal rate and they do not have growth failure or short stature. So these are maybe kids who are having familiar short stature. Mother, father, chote hain, then means the child is also short. So therefore, so when it is normally, it is diagnosed when the rate of growth is severely below the appropriate for the child age and gender. So that's important. So because the growth rate in for girls is slightly different from the growth rate in boys during puberty and especially during puberty time. So therefore, one has to understand this that very important to find out whether the patient is actually having short stature or not having short stature. But important thing to remember, if any child, rule of thumb, any child grows in less than 5 centimeter a year, he is that needs evaluation. He is most probably short stature. So short stature with a slow rate of growth should be evaluated further. Okay, this is for most of physicians to understand this. Now, the next thing is how do you evaluation of short stage? Okay, so because growth is a very dynamic process, so it needs careful documentation. Very important to take history. History since when is a short stage, or when is a parent observed? Is he the shortest in the class? Has there been any change in size of his shoes? Has there been, as he teased in the school, that, or teased wherever he plays that you are very short? So all these factors you have to find out about the child. Then you have to see the parents also, whether parents are okay, how they're tall or not tall, or they're short or they're short. So that also makes it. And since when do they feel that the child is short? If there is shortness after puberty is onset already. So when did the girl or boy enter into puberty? So all these questions are important. And then the examination is very, very, very important, because if you have a systemic cause, it's very simple. We have systemic cause, the child is short, maybe weight is less. There's a systemic cause, maybe respiratory cause, maybe cardiovascular cause, maybe a gastrointestinal cause, maybe something in the throat, which is chronic, tonsillitis, adenitis, all this can cause this thing. So very, very, and then very important measurement about the growth. How do you accurately actually? So you have to use a steadometer. We come to next slide, show you that with the help of a steadometer, you take this actual height, the standing height, then you take the sitting height, and then even if this baby is less than 2 years, then this is called infantometer, which is used for measuring the length. So then you calculate the mid-parental height. We'll talk more about in the next slide. And the height velocity, very, very important. How much this child is grown in the last 6 months. If he's grown like, if he's grown around 5 centimeters per year, that's fine. So that means you need to further get worried. You can just plot that same, whatever the points, plot them on the growth chart and see what's happening. Then you see the bone age, and then you use some specific lab investigation. If required, you do them. So this is how you do with a chart. This is how you evaluate a patient of short stature, which every physician should know. So what are the various oxycultural, data that are relevant to measure to say that is really or not really she or really is short? So you need the mother's height, you need the father's height for finding the genetic potential of the child, you need the mid-parental height. So that mid-parental height will come from the father's height and the mother's height. And we'll tell you the formula in the next slide, that what is the formula for girl and what is the formula for boys. Then you have to do a serial height measurement. So you cannot on one ground. Maybe if there's a lot of difference in the height, then you can say. But if you find only little difference, then you do a serial measurement. So after 3 months, after 6 months, after 9 months, what is happening to the height? Is the height maintained the same? Is it decreasing or increasing? What is happening? Okay. The height velocity is very, 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 very important. So the height velocity will tell you whether the child is going west or not. The birth weight, there are a lot of babies who are born, small babies, 2.2, 2.4. So SGA babies who are less than 2.5. If these babies do not catch up by 4 years of age to their respective height and weight, so they will ultimately have to be failure or short stature. So you have to keep an eye on the birth. And 90% of the babies do well who are less than 2.5. 10% of the babies do not catch up. So they have an issue. So therefore you need to assist them, whether you use the nutrition point of view, whether you use the growth hormone. So there are a lot of things in that case also. So very important to do the sitting height and then the height ratio, or the upper segment, lower segment. So there are many conditions, especially skeletal dysplasias, chondrodysplasias, many cases of girls with Turner syndrome, with boys and girls with Down syndrome. So these kids will have an upper segment more than the lower segment. It'll be disproportionate. Especially in skeletal dysplasia, you'll have disproportion. Like achondroplasia, dyschondroplasia, you'll have spondylosis dysplasias. So you'll have disproportion. So that's why. Then finally, bone age. So all this together is very important to be done when you do a child with short stature. So these are basic thing measurement to be done. So this as Toto has to be not just with the height only. So oh, is a short stature. So everything has to be seen. Graph plotting has to be done. We have to measure seal height measures. You have to do bone age has to be done. So all these things, parents, these things, genetic potential has to be seen. Now, this is a this is the most important, slides in as far as growth is concerned. You have to take the height of the patient. The height is taken with help of a steadometer, as you can see here. This is what we're doing here. So we keep the patient, standing against the steadometer and use this movable headpiece to bring it down on this thing on the child's head and see. And this will be the total. The most important thing is that all the, the foot, the ankle should be touching the plane. The buttock should be touching the plane. The back should be present, occiput. All should be in one plane, and the child should be looking in the front in the flank. So when he's standing in this position with in deep inspiration, and then he will be able. Then you measure. This is the actual height of the child. So that's why you have to measure the height properly. So then you can do a sitting height. The sitting stertometer will help him in sitting height, the height of the parents. Now, in cases of girls, it's minus 13. In case of boys, it's plus 13. So there's a difference of 13 in an adult girl and an adult boy when this is what has been taken. So now taking that into consideration, so if the formula for a girl is father's height minus 13 plus mother's height divided by 2. For a boy, it's father's height plus mother's height plus minus 13 plus 30. So plus 13 divided by 2. So you minus 13 in girls, you plus 13 in boys. So this will give you average the genetic or the target height or the mid-parental height. Okay, so therefore, then you have a target centile range, and the range is mid-parental height plus minus 6. So up, down, plus minus 6, you will have a range. So if the child is like, suppose if he's 166, so the range will be minus 6 will be 154, plus 6 will be 166. So if he lies within that range, he's still in okay, he's not short, or he's okay. So that's important. So this calls target centile range. Then there's a weight. Weight is very, very important. There are many conditions where the weight is affected, height is not affected, and the many conditions, height is affected. Weight. So on those grounds, you can have the idea. You can, you can decrease your, diagnosis easily and make it, okay, this is a diagnosis problem. So pubertal staging, very, very important part of oxology. There are a lot of girls who are going to early puberty now, having menarche at age of 9 years, 8.5 years, which is very early, and then finally landing up very short. So we have to be very careful. And I think by the age of 7 years, the girls should start to seeing pubertal status also. And if any mother comes to you at girl of 6 years, 7 years, saying that she's a breast development, go ahead and see the pubertal staging and do it and see what's happening. So very, very important after age of 7 years, maybe after age of 9 years, in boys, start doing pivotal staging also along with it. So bone age is very important. There are various methods doing bone age. There is the TW2, TW3, then now we have the bone expert, then we have the Grulish pile. So these are various methods of doing the bone age. So according to the bone age, and so taking all these things into the mid-parental height, the bone age, your pivotal staging, your weight, your target, then you decide what is to be done. Okay, so this is a very, very, very important oxology of the child. Now, so again, this is the same formula which I told you: mid-parental height, father's height plus mother's height plus 13/2 in boys, girls, father's height plus mother's height minus 13/2. And if the child is below the mid-parental height in the chart, then then we say that we sit. So if the difference is 6 to 10 centimeters lower than the mid-parental height, then we say that this child definitely is to be worked up. So he needs something is going on. We must work it up and try to find out. So that's very, very, so most pathological stature and start investigating this child. So if the child is below the mid-parental height in the chart, even when the height is not below 13, it needs to be followed up. So that need to be, you must keep on following up these children, whether they're still falling away the curve or whether they're catching up. That's something important to understand. Now, these are growth charts. Very, very important when you plot or make shorts here. You have to see, because you have a reference standard population. You're going to compare with the reference standard population. You're going to see whether this child is okay or not and what is happening with mid-parental height. So if you plot the mid-parental height on the growth chart, you will be able to see whether this child is growing well or not. So that's very, very important. So plotting growth chart, following up with the growth chart, what's happening. The growth charts, these are various growth charts, the CDC growth charts, the IAP growth charts, and then you have your KN Agarwal growth. So there are various growth charts. There is WHO growth chart. So you have various growth. But important thing is to plot and try to use country-specific growth charts and plot it on the growth chart and then see what is happening to the child. So height velocity, very, very important to understand that. So there at least 6 months gap should be there in order to calculate the height velocity, and reliable calculation of height velocity. So in children older than 2 years, so in first year, there's an increase of 25 centimeters. In the second year, the increase of 10 centimeters. In the third and fourth year, the increase of 7 centimeters. Fifth or sixth year, increase of 6 centimeters. 7 years to puberty, the increase of 5 centimeters. Mid puberty, 9 to 10.5. So therefore, you have here, a good way of finding out that if a child, the rule of thumb, if any child growing less than 5 centimeters, whether it's infant, whether 2 years, 5 years, 6 years, this child needs evaluation. Okay, the other important parameter, I already told you, height is very important, weight is very, very important, mid-parental height is very, very important, the upper segment, lower segment ratio is very important, the arm span. So basically, if you have a child who is, at birth, if its upper segment is around 2 and lower segment is 1, that means there's something abnormal. So it could be achondroplasia, it could be dyschondroplasia, it could be another cell death present. So at birth, the upper segment, lower segment is 1.7 is to 1. At 3 years, it is 1.3 is to 1. At 7 years, is 1 is to 1. At puberty, is 0.85 to 0.9. So you can understand that this is how it goes, the upper segment, lower segment changing. The arm span and height, 1 to 7 years, it is 3 centimeters. 8 to 12 years, it is 0 centimeters. Puberty, it is plus 4 centimeter in boys and plus 1 centimeter in girls. So you have, the measurements, the parameters in such a way, so you can say that. So basically, this parameter are equally important. So if you have a child whose arm span at 8 years is, is more, like 4 centimeter, 5 centimeter more than the height span, that means this child may be having, a condition where there's tall stature, so it could be Marfan's, it could be, homocystinuria. So that's it. So basically, that's why important to have an upper segment, lower segment, and arm span. And this is the the finding which you find on upper segment, lower segment birth at 3 years, at 7 years. The arm span is 1 to 7 years, less by 3 centimeters. So that means the arm span is less than the height by 3 centimeters. 8 to 12 years is almost similar, the the height. And puberty increases by 4 centimeters in boys and 1 centimeter in girls. So if you have a boy who is, like if the arm span is, around 8 or 9 centimeters, then something to consider. So the growth curve is very, 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 very important measurement key. And why it is important? Because, as you know that when you take the growth curve into consideration, this I'll just explain to you very nice. So this is pathological, the dark circle, constitutional, the white circle, familial is, when they are familial, it's like, when this thing is familial is, that the more mother, father short. So therefore, in this case, also the female is there. So what you find here is this is pathological. You see the growth is going like this and then coming down and going this. Then this is, the parallel to the third centile, the small white circle, and then the crosses are there also. So basically, what we're getting from this is that this distinguish normal growth from the pathological. So this dark circle one is pathological, dark dots are pathological, the blank dots are, it's most likely constitutional, and this cross are familial. So therefore, with the help of this growth curve, if you follow up the pattern of the growth of the child, you come to know whether it is normal growth or it's pathological. So below average height and weight would parallel the normal curve. So in most polyfamilial short stature and constitutional growth would have. So let's take a quick example of how do you plot on the growth chart. You just first take the name and the date of birth of the child. You've taken the name and date of birth of the child, then after you have to take the parents' height, mother's and father's height. You take that height of the mother and father to find out the mid-parental height. Okay. Then after once you find out the mid-parental height, you plot on the target height here. And once you've done that, then you take the child's height and weight and then see what's happening. So measure the height with the help of steadometer, measure the weight, and then you see what's happening. So then once you've done this, you plotted height and weight, you go and then chart and see at which percentile the patient is on. So the patient is on which centile? Is it on third centile, 10th centile, 90th centile? So which centile the patient is on? That's important to understand. So you have to do that. So therefore, they want you. So let's take an example. This is the height of a 9-year-old child. This is his weight. So he is, very, very short. When very, very low below the third centile. So very, very short. And then when you have this thing, the height and weight, the height and weightage to see which is one. So once you have done that, you calculate the height and weightage. These are some things which you will, as you practice, you on the growth chart, you understand. So the height is you draw a line perpendicular on the 50th percentile from here, and then draw a perpendicular line downwards. Here also draw 50%, then draw a perpendicular line down. So therefore you have this. This is the 3.8 here is your height, height age, and around 5.2 is your weightage. So as you can see here, the height is more affected as compared to the weight. So that's why it's important to understand that there's still, some parameter which is there and which is not there for it's not able to, you can say that this child is short and weight, but height is more affected than weight, so this is most likely to be endocrine cause. So by just plotting on this, you've been able to tell that whether it's an endocrine nutritional cause, and you should go on that line and see the patient. It's very, very important. As I told you, pubertal status is very, very important because there are a lot of girls going early puberty and a lot of boys also. So this makes difference. So this is a pubertal staging girl. So there is no breast development, breast budding start at stage 1, and then breast stage 2. So stage 1 is nothing is there, stage 2 is breast budding, stage 2 is breast, little breast small, and and then this thing areola breast small increases and the areola projects above the breast. This is adult side. So this is what you will see in cases of girl. In case of boys, their phase 1 is basically nothing is there, just testicular volume less than 4 ml. Stage 2 is when the testicular volume increases more than 4 ml. Stage 3 is the more increase of testicular volume, around 8 to 10 ml, long increase in size of penis. And stage 4 is that further increase in testicular volume, a long increase of penis. Stage 5 is adult side. So that means already 50 to 25 ml of testicular volume, and along with that good penile limb. So that's how you find out this thing. Pubic hair is the presence of pubic hair, and and there is no pubic hair. The presence of pubic hair, stage 1. Stage 2 is a presence of good pubic hair around the pubic rami. Then the spreading of the pubic hair, more thicker pubic hair, and then finally adult type. So that's how you have to see you have to see the genitalia, you have to see the pubic hair, you have to see the axillary hair, and you have to see whether in case of boys, what is the testicular volume, and in case of girl, whether menarche has started now. So it's called SMR, sexual maturing rate, SMR. Okay. So what is the sexual SMR of this patient? What is SMR? Sexual called. So that according to drug. So next is bone age. As I showed in that slide, there's something in the part axology. So bone age is also there. So bone age tells you that what is the skeletal maturity, what is the 4 years, 6 years, 8 years, 10 years. It is very closely related with the SMR, so the sexual maturity. So boy is, born is 10 years, actually is 8 years. So most probably he is already having SMR closely of 10 years. And if the born age is like 14 years and his age is 10 years, then most probably he is already in puberty. So if you examine the boy properly, you'll find. Or if the girl also might be having menarche. So that's why it correlates to the SMR. It tells you how much still potential is there for a child. So if a boy, for a girl, till a born age of 14, the growth will occur, and for a boy, a born age of 60, growth. After growth will stop. So that's why, and it gives good idea of adult height prediction. So we are using, the various that you can use. Now these are available on the, your phones. So for TW3 for Android and for Glenzatte for the iPhone, there are these available. So you have the software, the app is there. You can always see on that. So this was the basics of growth and basics of how you should do it, how we should approach a child for short stature. Now, what are the definition of growth parameters? Chronological age means calendar age. From birth, what date of birth till whatever date today, this is the chronological age. Then there's bone age. So age which at the bone maturation at the 50th percentile. So if you again draw the 50% down, this is a bone age. The height is age for which the height is at the 50th percentile. The weight is age and with the weight is at 50%. The target height is mid-parental height plus minus 6 centimeters. Okay. The predicted height assessed is from the bone age. So what is the prediction of this child will be from the bone? So plus minus 6% is of both the sides will be the third 90, or in other words to say the target centile range. So what you define or who needs evaluation? So you have already seen you evaluated, you have found it, you plotted. Now, who is the child who needs evaluation, who needs further investigation? So that's why if the child is below third centile or 2 standard deviation below the mean, that is on the growth chart, as you can see here it's on the low. So that means he needs evaluation. If excessively short for mid-parental height, okay, or target height, he needs evaluation. You can see here, this is his mid-parental height, and he's here. So this is definitely very short. He needs evaluation. Okay, if the growth velocity less than 25 percentile over 1 year, so in other words, if the child is going less than 5 centimeter a year, he needs evaluation. And if he falls across 2 measures, if he's going on the 50th percentile and now he comes down to 25th percentile, and after 3 months comes down to 10th percentile, he needs evaluation. So these are the things you must remember. See, like here, he's falling across 2 measures percentile. This is with the mid-parental height comparing. This is below third. So these patients need to be followed up properly and need evaluation, need investigation also. Okay. So what are the causes of short stature? The most common cause is माँ बाप छोटे बच्चा छोटा है, माँ बाप छोटे बच्चा. So genetic or familial short stature. Second is constitutional delay growth and puberty. You know that माँ बाप भी छोटे, father आके बोलते हैं मेरी तो दाढ़ी मुझ 18 साल पे आई थी, and I grew only after when I reached my 10th standard and 11th standard. So this is constitutional. So maybe that's there in the child also. Then there are, pathological causes, maybe endocrine causes, nutritional causes, GIT causes, renal causes, SGA, psychosocial deprivation. These are all the causes. Then finally, when there is no cause, idiopathic short stature. There is no cause and we find it. So people come, a lot of doctors will come with, कि sir मेरे बच्चे की height नहीं बढ़ रही और मेरे को लगता है छोटा ही रह जाएगा. So we all investigate are showing it's normal. Everything is normal. So that is idiopathic short stature. So what are the endocrine causes of short stature? Being an endocrinologist, I'll tell you what endocrine causes of short stature. Anything if there's any problem within the hypothalamic pituitary GNF axis that is causing this means there is a short stature. So disorder hypothalamic pituitary GH or F axis. So growth hormone deficiency, hyperpits, then IGF-1 deficiency, then growth hormone insensitivity. Okay, so these are all will cause your to be short stature. Then hypothyroidism, Cushing syndrome, disorders of puberty, disorder of parathyroid glands, disorder of vitamin D metabolism, a poorly controlled diabetic child that will cause short stature. So puberty, early onset of puberty, parathyroid glands, the problem will be there, disorder of parathyroid glands, vitamin D metabolism, rickets, different type of rickets, hypophosphatemia rickets, other one, nutrition, all will cause short stature. So you have to remember these are the causes. The common will be with the growth hormone deficiency or hypothyroid. So how do you evaluate, coming back to the evaluation, history of growth? As I told you before, history must be taken. The family history is very important. When the heights and what were the growth patterns during their time, accurate height measurement of the child, father and mother, good physical examination, lab investigation to exclude diseases. If you're suspecting liver, you do liver. You're suspecting respiratory, you might need to XHS and do a CBC. If you're suspecting something in kidney, do a KFT. So left hand, wrist, and X-ray to assess skeletal maturation. Okay. So left hand, wrist, X-ray to assess. So see the skeletal maturation. So growth hormone testing if indicated. So you will do a growth hormone testing if it is needed. So MRI scan if indicated. So MRI scan if indicated, you will do it. Okay. So this is how you evaluate the growth disorder. So that's something that's so these growth hormone testing and all should be done in centers where they are you have facilities and you have persons monitoring these children who are being growth hormone testing is being done. So investigation basic you can do is a full blood count or a CBC, you can do a CRP, you can do out urine creatinine and urine through lot renal tubule disorder, LFT. Stool should be done because we have a lot of parasitic infestation in our countries, just rule out. Serum iron TIBC can be done, calcium, phosphorus, bone age, as I already told you, thyroid function tests can be done by the physicians. So these things further on, like it should be done especially karyotyping for girls, skeletal survey, IGF-1, IGPF, growth hormone stimulation. So I think this has to be done with the, doctors who are dealing with or specialized for it, So a very quick algorithm and a big way of making you understand, this thing for every physician is that if the child is less than percentile, after you plotted 5 if he is appropriate for the parental height, you have compared with the mid parental height, is appropriate, then it is most likely familial. Okay. Now, if he is not, and his history is there of having low birth weight 2.2 kg, so then you see whether it's dysmorphic or non-dysmorphic. If there is dysmorphic, okay, if there is dysmorphic, then it is more, I see whether it's proportional or disproportionate. If it is proportionate, it's likely to be a Turner syndrome or Russell-Silver syndrome. But if it is disproportionate, it's more likely to be skeletal dysplasia, achondroplasia, dyschondroplasia. So this is a very nice small, algorithm, or you can say just a small picture is telling everything. So, but if he is, if he's low birth weight and is not dysmorphic, is likely SGA. So SGA baby who's not catching up. Okay, so if it's proper parental height, then go familial. Now if he's not low birth weight, but he is on the obese side, okay, so then what is the next line of action? The next line of action, if he's obese, yes, then you should try to see most probably endocrine disorder, growth hormone deficiency, hyperthyroidism, Cushing syndrome, whatever. But if he is not obese, patient is thin, sign and symptom of organic disease, yes, most probably chronic disease. If there is no there is no signs of organic disease, there is delayed bone age, family history of delayed puberty, constitutional. But if there is no delayed bone age and family history of delayed bone age, So that means most probably psychosocial problem. So maybe psychosocial issue there and this thing. And that for that, you have to just change the environment and start doing that. So, but if there is no psychosocial problem, no, then you recheck, start all over again from the beginning, see where the problem is, because this is enough to pick up a case of short stature and find what's going on. Okay. Now, there's another evaluation. I think this is very complicated, but I think, if you, that one I think is very simple for everyone to understand and to, go for it, because I told you here also, if you, it's the same thing. Is the patient is dysmorphic or not dysmorphic? If the patient is dysmorphic, yes, is he proportionate? If he's not proportionate, chondrodystrophy, like me, if he's not proportionate, then you see for downturns. But if the patient is not dysmorphic, he sees growth velocity, sees weight, and C is bone age. So if the growth velocity is more than 5 centimeter per year and there's a delayed bone age, constitutional. And the growth velocity is more than 5 centimeter, normal bone age, projected height considered midparental height, familial short stage. But if the growth velocity is less than 5 centimeter, delayed bone age, and normal or increased weight, most probably is endocrine disorder. Okay, so this is another thing you can understand more. Now, what are the possibilities? So this is a very simple, I think everybody should know that bone age equal to height age equal to chronological age, a normal growing child. If the chronological is more than the height age, bone age equal to height age, is less than chronological, it is constitutional. If the bone age equal to height age is less than the, bone age equal to chronology is less than height age, it's most probably familial short stature. So here your bone is whatever, if your bone age is 7 years chronological, bone is 7 years, okay, that's fine. And your height age is actually coming out to be 8 years. So therefore, this is most probably familial short stature. But if you have a child whose chronological age is more than height age, more than the bone age, so that means most probably he's 8 years old. His height age is coming out to be 7 years old, and bone is coming out to 6 years old. Most probably is just pathological. It's more of this thing. So delayed bone age makes a lot. The bone age make also helps a lot in coming to a diagnosis. So these are the various possibilities. Constitutional is so the height age. So if bone is height age 6 years, bone is same, and chronological 7 is most probably constitutional. Nothing else. So let's go through one two cases. Quick cases. 11-year girl who has always been short for her age. His mother is 125 centimeter. The father is 165 centimeter. The physical examination is normal. The breast is standard 2, pubic hair is standard 2. So what should you do next? So what should you do? The physical examination is normal. The breasts are standard 2, pubic hair is standard 2. What should you do next? Next should be, calculate midparental height? No. What you should do it or not? Yes, we should do it because the complaint is that my girl is short and she is 125, 165. So physical exam and breast are just standard 2, pubic standard 2. So calculate the midparental height. Should you obtain a bone age? Should you start doing a lab screening or replant on a specialized growth chart? So what should you do? So basically, here you calculate midparental height first and see whether this child is going there. So midpoint height was calculated for this girl. So it was 165 minus 13 plus 152.5 divided by 2. It was coming out to 152.5. The midparental height was this. The most probably diagnosis is you plotted this downward and you find that this child is following the path. It's on the third centile. It's not going away. It's going on this thing and almost will reach 152.5. So therefore, most probably this is just familiar short stature, or that means this is familiar short stature, which is because the parents are told. So otherwise, therefore, the likely is familiar short stature. So then familiar short stature, this is not constitution. Why it is not constitution? Because there is no history of delayed puberty. Now this girl is only 11 years old. The physical examination breast is already standard stage for pubic hair. So there is no delayed puberty. So when there is no delayed puberty, there's no question of delay. So therefore, most probably it is a case of familial short stature. And the important thing to remember that in the bone age is delayed in constitution with normal and familial short stature. The timing of puberty is normal in familial and timing is delayed in constitution day. And the hurdle tide is short and familial, whereas in constitution it is normal. And therefore, the parent puberty is at a usual timing in familial short stature, where in constitution it is often delayed. Okay, so this is something you must remember. And very main thing is growth in the first 2 years is normal in familial short, but slow from mid-FS to a child in the case of the constitutional. And go 2 years to puberty is normal, very slow in case of constitutional. So this is giving a good idea. And bone age is delayed in constitutional. Bone age is normal in case of the familial short stature. So these are how you different, because these are two commonest cause of short stature, as I told you in the beginning. Okay, another case, a girl of 10-year-old, height 110 centimeters, weight 22 kgs, target height 57. What is the height age? What is the weight age? I already told you how to calculate height and weight age. So the height age is 5.5, weight age is 7. So what do you find in here? The girl is 10 years old, the height age is 5.5, the weight age is 7. So the height age is more affected and the weight age is more than the 20 years. So this one, I remember I told you that if the height age is more affected than the weight, it is most likely to be endocrine cause. So therefore here you can see that. So therefore, let me plot the same thing on the growth chart. So this girl, this is the IP growth chart. You can see here, dot, this is down perpendicular, this is the height age, sorry. This is the height age, this is the weight age, and this is the mid-parental height. So definitely the child is short, and the height is more affected as compared to the weight age. So this girl is most probably endocrine cause. So here I'm coming on to what you find. So 10 years, more than 7 point, more than 5. So the height age is 5.5, the weight age is 7.5, the chronology is 10. So this is more effective. So the child is short and thin, but height is more affected. So weight is spared. So most likely endocrine disease or maybe a syndrome or also maybe possible cellular dysplasia. So this is now coming on another case, 14 year 6 month old boy is shorter in the class and no problem at school. He's the shortest, 14 years, 6 months. Always a small boy, no chronic disease. Father didn't go till he entered college. So this is a catching point. No dysmorphic features. CVS respiratory, all system examination normal. Height is 135. The weight is 37 kg. The test volume 2 ml by liter. So puberty is also delayed. The height is also delayed. 100. So these are catching points. So they see the status of the pubertal status. G1, P1, A1, right and left. So his testic volume right to, there is no pubic hair, there is no axillary hair, his genital hair is just one. Okay, so this is a point. So you can see if you plot this on the growth chart, this is how it's going, and this is how the child is going, and then it goes downwards. Okay, this is how his weight is going, weight is the same. So his height is affected more and weight is less affected. So therefore, father's height 165, mother's height 152, mid-parental 165, born age is 12 years, normal routine, all the tests done was okay. Normal thyroid functions, low IGF-1 for age, but normal for bone age. So this is people LH and FH people, all this is all the 14-year-old child, still people LH. So most likely it is CDGP. So nothing was done, only testosterone given to him once every 4 weeks for 2 months. He immediately caught up and started picking up. So as you can see, he caught up very well. So he almost reached his genetic potential. Okay, so very interesting case. So there's another case where there's a girl of 11-year-old. The history of recurrent otitis media. Her mother is 165, father is 172. So physical examination, there's multiple nevi, low posterior hairline, webbing of the neck, widely spaced nipples, increased carrying angle. Her breast and pubic are in stage 1. So she is not entered puberty. Okay. So what do you do next? You calculate mid-parental height, yes. You obtain the bone age, you do the lab scanning, replot and specialized growth chart. So in this case, we do almost all the things. Why? The clear clinical point of female who present with unexplained short stature and no family history of short stature have a chromosomal karyotype of home. So must do in all short girls a karyotype to see whether there is a mosaic Turner or whether there is a whatever Turner syndrome. There are many types here because the X can be affected many ways with this. So there's absence of X chromosome, there could be a modification of X chromosome, could be the bifurcation of X chromosome, there could be duplication of X chromosome. So all this will result in. So consider that you do an FSH, and if the patient will have old recess of primary ovarian failure. So consider Turner syndrome, any girl who presents unexplained short stature. The phenotype is very typical in this girl. There was very big neck, and there was a high arch, but there was increased carrying angle, broad chest, and presence of your short and fifth metacarpus. But in most of the girls will not be present. So consider TSH level because there's high risk of hypothyroidism with this. So just in a nutshell, the important history taking, physical examination, medication history, growth chart plotting, calculation, the mid-parental height, the target height, the height velocity, height age and weightage, and then you finally decide what it is, what direction you have to take. And that I showed you a very nice algorithm that if it's like this is very simple. So you can pick up and go ahead for the dirt. So back to you. Thank you very much for everyone for listening. I'm ready to take questions if there are any questions.
Thank you so much, sir, for the wonderful presentation. Now, I would like to request all the participating doctors, if you have any questions regarding this topic, please paste it in the comment section so that I can put forward it to sir. Sir, we have already started getting the questions. First question we received: what is the importance of obtaining a detailed medical history, including prenatal, perinatal, and family history, when evaluating short stature?
Okay. So see, when you come to a prenatal history, you come to know that your mother has not taken properly her nutrition. She has had any problem. She had just a second, just 1 minute. Okay, meeting I'm confirmed. So you take a history. Your history prenatal is very important, and because that will give an idea of what exactly is happening. And once the prenatal is there, you go on to further on to see what is happening, and then then you do that's once you where the mother you get the mother history very proper that with nutrition is proper, everything is fine because there will be many causes of having IUGR and SG in these babies because the mother nutrition is factor. Mother may have a hypertension, mother may be diabetic, mother may be preeclampsia. So all this will make a difference as far as nutrition of that concerned the baby also. So then that's important. Then once postnatal, see what's the birth weight, what is the length, what is the head circumference, and follow up that on the charts and see what is happening to the patient. So all this will make a difference in the. And then if the mother is short and she had a say that the chances that there's maybe a baby will have some ESGA or maybe baby will be a short baby. It's difficult to say, but because not it may not be necessary all the time that if mother is short, that the baby will also be short.
Thank you so much, sir. The next question that we received is: what is the significance of growth charts and how to interpret them? And along with that, doctor also has written, how can you identify growth velocity abnormalities?
Yeah, so as I told you that the growth charts are basically to have an idea if there is normal growth or it is pathological. So if you find that with the help, when you plot the height and weight on the growth chart, if you find that there is a growth of less than 5 centimeters in the 1 year, or if there's less than 2.5 centimeters in 6 months, once you plot, then you can find out. So that will give you an idea that you need to evaluate this child, you need to investigate this child. So that's one thing is there. That's why the growth. The second thing is, the velocity is basically change in height over change in time in years. So if you have a child who is 119 centimeters, and after 6 months he come back to 121.5, but the parents are complaining, my child is short, my child is short, and you plot it's coming on third centile. So if he comes back to you after 6 months with 121.5, so he has gained 2.5 centimeters in 6 months. So what is the velocity will be the change in height in centimeters upon time in years. So here it is 2.5 centimeters. We put 2.5 centimeters. So they're in 6 months. So that it is 6 months. So 6 months means what you will do is you will divide by this thing. So 6 months half a year. So 2.5 divided by half a year. Okay. So that'll be 2.5 into 2 will be 5 centimeters. So that means he's doing well. So this change in 2.5 centimeter in 6 months is good enough for this child to say that 5 centimeter per year growth rate. So this will give you an idea of this thing. That is why the then their height velocity growth charts are there, separate growth charts there, where there you can see if the child is within less than 25th percentile in the height velocity chart, that means he's not going well. So that's also there.
Thank you so much, sir. Sir, it is already over the time. If you allows, then shall we take one or two more questions?
You can take.
Okay, thank you so much, sir. Another question that we have received, what are the red flags that suggest an underlying medical condition or syndrome associated with short stature?
So the red signs are that, as I told you, first of all, if the child is going less than third centile, it's a red sign. If the child is going less than 5 centimeters a year, it is a red sign. If the child is cross two major centile, it is a red sign. If the child SDA child, SDA child, SDA child, if a child SDA is after the age of 4 years, he is not going parallel to what he should be going, that is a red sign. If the child, even a normal, the child with normal high, this thing, you feel that he is growing well, but if you find a child height velocity is less than one standard deviation over 1 year, or if it is more than 1.5 standard over 2 years, that also child is evaluated. So these are the things where you have to evaluate the child, and you have to, these are red signs. If the child is having a systemic disease like very respiratory, tuberculosis, or abdominal, or cardiac, so these children will be kept into different. So they will have a different red sign. So red sign is that they are not going well. They will not be weighing weight also well, and the bone age will not be increasing so much. So there will be a delayed bone age, so the weight will be affected and the height. But most of these kids will have more effect on the weight as compared to height. So this is all the way you picked up these cases. So as I told you, the red sign in these cases will be this, the growth pattern. So this will give you, so if it's crossing two major signs, the red sign. If you're going less than third centile, it's a red sign. If you're going less than 5 centimeters, it's a red sign. If you're going less than 6 to 10 centimeters to the mid-parental height, that's a red sign. So if your mid-parental height is on the 50th centile and you are going on the 10th centile, that means a mid sign. So you're already going 6 centimeters left. So this is a red sign. And another red sign is, for as a clinical, if the child's shoes are not changing in the next 2 years, if you have a growing child, 2 years, 4 years, 5 years, so within 1 or 2 years, the shoe size is changing. If it does not change, there is a red sign. If there is no change in the height, in the school, the measurement is, if the child is shortest in the class, that is also a red sign in case the parents are good height. So these are all the things you have to look after.
Thank you, sir. We are taking last question of this session, and that is, what are the potential complications and long-term consequences of untreated short stature in children?
So there is no long-term complication. He just will be a short guy. So in short, he will psychological, you have problems in future. So when he goes to enter the army, he cannot enter the army because there's specific height. You can't go to army. If the child is short, maybe he will not be able to enter many games, participate in basketball, many things because he's short. So, but they should still be very happy if they're still having, because there are many things short people can also do which tall people cannot do. So overall, I say there's no complication. If there's familiar short, familiar short. You can't do anything about it because the child parents tall and not tall. Unless the parents had some disease in the childhood, then okay, then we say, oh yeah, this child is short, he needs to be evaluated and investigated. So that's the thing. But there's no complication of short stature except for psychosocial stress, being a short, being bullied, not being able to play, all these other. In the school bullied, short, chotu hair, chotu yeka, chotu woga, chotu. These are things only.
Thank you so much, sir, for explaining all the things very well. I hope all the questions you got answers. All the participating doctors, thank you so much for joining today's session. And I would also like to thank Dr. Kochar for giving us his precious time and shared all the details that is necessary for this topic. Thank you so much, sir. With your due permission, shall we close the session?
Yeah. We can close the session. Yeah.
Thank you, sir. Have a great day.
Okay. Bye.